So across the world, this use of echo is known as a point of care ultrasound, that is POCUS examination. And POCUS examination includes a basic echo where you just go click a photograph, take a video, and you diagnose based on them. So suppose somebody comes in with a BP of 60 and the patient is in shock. But when you put the echo probe and you say, oh, the inferior vena cava is empty, then you know that this patient needs volume. But if you say no, the IVC is full and engorged, then you know that there is much more to the case and there is no point just blindly giving IV fluids. It may turn out to be a disaster later on. So the first use of echo is what is known as spotters. So in point of care ultrasound, we do what is known as the basic echocardiography. And we pick out the diagnosis in simple 2D imaging, and the diagnosis is a spotter and we treat accordingly. The second advantage is when we are treating, say the patient is hypovolemic and was hypotensive, you are giving fluids. If you do the echo every 30 minutes or 60 minutes, you will find that not only is the blood pressure coming up, you will find that the LV cavity is also getting filled up, the IVC is also getting engorged, and you will find a response to treatment. Contrary to this is a situation where you will see that the BP was low and it seemed hypovolemic and you are giving volume, but the blood pressure is not coming up. So that means there is much more to it and you need to have a more detailed look and probably need a more experienced echocardiographer to do this echocardiography. Now, this was one part. Second is a more advanced part where we monitor our patients daily during rounds or during troubleshootings. So if you look at echo, which is an ultrasound of the heart, you see the four chambers, then you see a pericardium, which is sitting on top of the chambers. Then you also see the vessels like the descending aorta and the inferior vena cava, and the ascending aorta, aortic arch, and the descending aorta. So when you are visualizing this, so in routine patients who are admitted to ER or intensive care, when we see them every day, I mean, we're just not happy with, say, the pulse or the blood pressure. Like it can be the pulse is 110 and the blood pressure is 110. There's a small change in blood pressure. Or it can be the pulse is 50 and the blood pressure is about 90 systolic. Or the heart rate is 110 and the blood pressure is about 210. So one is on the basis of the monitor, we make a diagnosis. Okay, tachycardia, bradycardia, hypotension, hypertension. Second is we look at closely at the blood pressure. So if the diastolic is low, I'll say the diastolic is low, the patient could be septic. Or the diastolic is low and the pulse pressure is wide, there could be aortic regurgitation. Or there could be any other features to suggest a hyperdynamic circulation. So till 10-15 years back, it was good that you come, you take your rounds, you have a meaningful clinical discussion, everybody feels happy, but then at the end of it, you move ahead. No, today when you take a round, you please do your clinical decision making. You should not use an echo without a clinical decision making. But after the clinical decision making, please put the echo probe and confirm the differentials which you have. So if I have a patient who's, say, running at a blood pressure or at a pulse rate of around 100 and a blood pressure of yesterday the heart rate was 80 and the blood pressure was 150 by 80. Today the heart rate is 100 and the blood pressure is about 140 by 50. So he's developed tachycardia, he's developed wide pulse pressures, the diastolic is dropped. Is my patient getting septic? Well, yes. So now I'll have to put in an echo probe. If I put a central line, it will tell me CVP is low. Maybe the patient is hypovolemic. If I put an arterial line, it will give me more accurate beat to beat blood pressures. And I'll say, okay, fine, this patient is hypovolemic and hypotensive. CVP will also tell me this patient is hypovolemic. Give the volume, but give the volume for what? The moment you put an echo probe, you will make out, well, yes, definitely the patient is hypotensive. Okay, he's not developed an acute coronary syndrome. His contractility is okay, good. and he seems to be hypovolemic. So then I know that this picture, at least you have ruled out so many things. So it's pure hypovolemia, and if the diastolic is low, it possibly is due to sepsis. And then say, for example, if I am still more evolved operator, I know sepsis also brings in a lot of changes to the heart, like the heart dilates, the contractility drops. So then I'll know, fine, these are the changes related to sepsis. Then at a still more advanced level, I'll say, fine, let me very objectively measure what is the contractility of the heart, what are the pressures in the left atrium, what are the pressures on the right side of the heart, and on top of it is the last thing which I'll come next. So, it tells me, fine, my patient's contractility is dropped, the heart is dilated, is probably septic. So now I am sitting with a heart which is contracting less, which is dilated. The patient is septic, but sepsis patients need more fluids. So should I give fluid to this patient? So I think that is one of the most evolved uses of echocardiography. So if as an intensivist I have to give fluids to the patient, okay, so I do what is known as fluid responsiveness. So in good intensive care practice, you don't ring up your registrar and say 500 ml saline de do. No, so we do what is known as a fluid responsiveness. That means we check whether, like, it's like astrology prediction, that if I give fluids to this patient, whether it will result in an improvement in his hemodynamics. Mark the word, I am not saying improvement in pulse and blood pressure, I am saying improvement in hemodynamics. So how do we do that? So one of the ways is simple, which is known as passive leg raising. That means you put the patient on the bed flat and you raise the legs. I'm talking in a very layman's language. I'm not going into details. So if the patient is 45 degrees head up, you make the patient supine and you take the legs up by 45 degrees and you keep the patient in that position for 1 minute. So what happens is 300 ml of volume, which is there in the capacitance veins of the leg, it fills in the pulmonary circulation and your pressures come up. So you are giving, it's like giving 300 ml of saline. It's a auto transfusion. You're not giving any exogenous fluids. So if you push in this 300 ml of saline, you will expect at the MBBS level, you will say if the patient was dehydrated and the 300 ml was required, then the pulse, the tachycardia will settle, reduce, the blood pressure may come up a little. Okay, and then I know, yes, if I give him another 300 ml from outside, it will be good for the patient. But suppose we do the passive leg raising and we say ki there's been no change in blood pressure and no change in heart rate, then I know probably this patient may need something much more than fluids, or fluids may do harm. This is at a basic level. Now at a evolved level, if I have to give a fluid patient, so I am telling patient has dropped his blood pressures, patient has developed tachycardia, patient looks septic, echo is consistent with a reduced pumping, okay, and the LV looks dilated. So I'm not a hero that I'm going to go and put in fluids in this patient. So what I will do is say I will do something like a passive leg raising, and here I do it with the echo probe on. So what am I trying to capture? Because my heart rate and blood pressure is already there on the screen. If the patient has a central line and an arterial line, they are already there on the screen. So what I'm trying to capture is by giving in this 300 ml of fluid from the legs into the circulation, is the cardiac output of the patient going to increase? So, there are different scenarios. Many a times you give, say, 500 ml of saline, nothing happens. Pulse doesn't change, BP doesn't change. So, there are two possibilities. Either nothing will happen, that means the patient doesn't need fluids, or patient needs much more than 500 ml for any change to occur. The second scenario is, so I give another 500 ml, is that the heart rate comes down, the blood pressure comes up, okay, and the cardiac output doesn't change. So again, I need to be very sure what is the point of bringing down the heart rate and bringing up the blood pressure if the cardiac output is not changing. So whatever fluid you are giving is improving the circulation, but it is not making a change in the cardiac output. So ultimately, if the patient is fluid responsive, and especially these tricky patients who have low pumping or chronic liver disease or chronic kidney disease or any other organ failure, heart failure, so these are the patients where you just cannot give fluids indiscriminately. And even in ICU, even a patient with a normal pumping, you cannot just push in fluids indiscriminately. So what we do is we keep the echo probe to image the left ventricular outflow tract, and we see whether the administration of fluid brings about a change in the stroke volume, and stroke volume into heart rate is cardiac output, so whether it brings about a change in the cardiac output. So suppose I give fluids, say, the blood pressure comes up, the heart rate settles, and the cardiac output increases. Good. Then I will come to a stage when I'll give fluids, the blood pressure will not change, the heart rate will not change, the cardiac output will not change, but the CVP may increase. So I'll say, fine, no more fluids. But suppose you were without a echo, you will say, no, no, the CVP is increasing, let's continue to give fluids, and you will end up producing fluid overload, which is harmful to the patient both in the acute and in the chronic setting. So this is one simple use. I think the most common use of echo in ICU, where the patient is hypotensive, we troubleshoot hypotension so that I know whether this patient needs Lasix, or whether this patient needs a vasopressor, whether he needs a inotrope, or whether he needs intravenous fluids, or is there any other mechanical support which he needs. Similarly, when the patients are hypertensive, and we scan them, so not every hypertensive patient will need a diuretic. So you have to be very clear clinically when the patient is hypertensive, whether he is experiencing a hypertensive emergency or a hypertensive urgency. And if he's experiencing a hypertensive emergency and urgency, you have to be very clear that you need to use a intravenous antihypertensive. But then, do you need to use a diuretic? So these are again situations where we immediately scan the heart and the lungs to see what is the functioning. Because remember always, the rise in blood pressure can, one, be due to the blood pressure per se, or it can be reactionary to any other situation. Third situation which we deal very commonly with in the ICU is when patients are on the ventilator, okay, or patients who are septic and have been there for long, and we are not able to come off the vasopressor support. So we scan these patients every day to do two things: to set up the fluid requirements, to set up the vasopressor like noradrenaline, adrenaline requirements, to set up the inotrope requirements like the use of dobutamine or levosimendan, and not only that, to also fine tune my ventilatory settings. Because if I have if I have a patient who is hypotensive, one of the reasons could be that my ventilator settings are not appropriate and I'm causing too much of stress to the right heart, and the right heart is sort of dilating because it cannot push in fluids adequately into the lungs, blood into the lungs, because there is a huge intrapulmonary pressure because of inappropriate ventilator settings. So, this the use of this echo machine has now become a regular part of intensive care rounds and ER rounds across the world. And many a times we realize that there are things, if our clinical decision making is good, there's a good team, you discuss clinically, you put the probe, you'll pick up the diagnosis, what you have thought of. And many a times we do miss, and when we put the probe, there is always a surprise for us. And then of course we start the treatment and we see the response to treatment. So this is how I use the machine. And when I say hemodynamic monitoring, so one is the naked eye monitoring, where you look at the image, you'll say big RV, well, pulmonary embolism; small RV, patient is dehydrated; big LV, low contractility; small LV, hypovolemic patient; big LA, enlarged left atrial pressures; big RA, suspected pulmonary embolism; IVC full, no fluids; IVC empty, lots of fluids. So this is one very, very crude way, but then it works. If you're trained, it works, and it really makes differences in outcome. You get a early diagnosis. You start treatment early. If you're in a smaller hospital, you can take that screenshot and you can shift the patient timely in a cardiac ambulance to a bigger hospital. Now, the second thing is, in monitoring, we objectively measure the pressures. So echo is not a pressure transducer. Echo will tell me the area of, say, LV, area of LA, area of RV, area of LA. And when I take the area and I multiply it, I can get the volumes, So A square is equal to area, A cube is equal to volumes. So we take, these are all the principles of physics, that in a chamber which you see, how you can measure the volumes of a cylinder. And from the volume, we use equations and we extrapolate it into pressures. So if I have to derive pressures out of echo, I have to derive it from the calculations of area and volume. So for my pressures to be correct, my area and volume assessment has to be correct. Even half a centimeter change in the length or a 1 centimeter square change in the area will produce a huge error in the measurement of pressure. So I have to be very, very clear that my assessment of area and volume is correct. So for hemodynamic monitoring, you really have to get very good quality images. And not only good quality images, say I am taking the morning rounds and my consultant is taking the evening rounds. If we don't do it the same way, there'll be a marked difference between his readings and my readings, just because we are each doing it our way. So in hemodynamic monitoring, the practice is defined. If you take this image, this should be at 12 o'clock position, this should be at 1 o'clock position, it should look like this, the direction of flow should be like this, the angle between the transducer, the Doppler and the flow beam should not be more than 20 degrees, it should be as less as possible. So there are many caveats, so that the reading I take, you take, my consultant takes, they are taken in the same way. So we understand that the changes which are taking place in the patient are correct, and we also understand that we are not missing out anything which is happening just because we all of us do it our way. So that is the beauty of hemodynamic monitoring, one of the most evolved form of echoes, where you just can't put the probe like this and like that, and you need to put it and get very standard images and measure them in a very standard way. Each and every parameter is defined so that my calculation of IVC size and your calculation of IVC size matches with the correct calculation of the IVC size. So typically, what are the pressures we measure? So for the right heart, we can measure the right atrial pressures. Okay, that is one. And these pressures are derived indirectly. Then we can also measure the pulmonary artery systolic pressures, we can measure the pulmonary artery diastolic pressures, then we can measure the mean pulmonary artery pressures. And for the left side, we can have an idea of left atrial pressure, whether it is elevated or not elevated. And we can also have an idea of stroke volume and cardiac output. So if a hemodynamic monitoring report is there, then I'll always say that whether the what are the right atrial pressures, what are the pulmonary artery systolic pressures, pulmonary artery diastolic pressures, then what are the left atrial pressures, and then what is the stroke volume, what is the cardiac output, is the LV contractility normal or it's reduced, and of course the last thing is that whether the left ventricle, is it stiff? That means, is there something known as the diastolic dysfunction of the left ventricle? And in the end, whether the valves are normal and the pericardium is normal. So I have a real look at the heart. And when I work as an intensivist, I don't look at the cardiac monitor to bring it to the normal. I look at the echo based pressure measurements. I decide what is to be done and which modality is to be used, which modality is to be thrown out, and other than that, how do I change my ventilator settings. So as an intensivist, it is very useful to me in the management of hypotensive patients, hypertensive patients, acute chest pain patients, acute breathlessness patients, septic patients, trauma patients, and other patients who are bleeding. And I can exactly decide, okay, now should I go in with IV fluids? No, I think he's got enough IV fluids. We need to slow down. And if there is any change in any of the vital parameters, I have an idea of why this is happening.